Good evening, all the students present here. Here today we have the topic Obstetric Emergencies Class 2, and the speaker that we have here is Dr. Neeraj Kumar, who is a Associate Professor, Anesthesiology and Critical Care, AIMS Patna. Thank you, sir. So you may start. Thank you.
Okay, thank you. I think soon many of the other means aspirants will also join. And just one disclaimer before that start, I think already has been told by Fatma also. So meanwhile, what is our plan for today's class is that we will be discussing a few important aspects of various obstetric emergencies first, and then simultaneously what I have done, I have kept few important questions there of different topics in which many of the important topics that is useful for EDIC 1 is being added here, and all these means lectures have been prepared from a standard critical care textbook like from Irwin Rippe, and few of the things has been taken from the from your journals as well. But before starting this class, I just want to request you all the students, that please don't unmute your mic and don't try to disturb the class, because it is very important. Many of you have paid for this, and I'm sure that it will be of much use. And meanwhile, what I have kept, that I have kept few questions like type K question and type A questions in between, so that you all can answer. But while answering, you can use the chat box for typing either true or false statement, or which answer is means you feel that which answer is correct for type A questions. Okay. So what I feel that this will be small instructions for you all. And I hope that at the end, if you have any problem, then I have shared my email ID as well as my X account ID, so that if you have any issues regarding today's class, you can discuss me on that. Or meanwhile, we can discuss in between also if you have any problem. Okay. So you can straight away, you can ask the questions in the chat box. So we all are aware about this obstetric emergencies, and it is one of the most important topic that has been very frequently asked in EDIC 1 examination. And why these obstetric emergencies are important, because we always feel that there are fixed number of topics which is especially reserved for the obstetric emergencies, right? So many of these topics, like you will feel that what will be the obstetric causes and what will be the non-obstetric causes for these emergencies. So I will tell you that how these causes are important, and what things that we have to remember for your upcoming exam. So now coming to the first part is, before that, I just also want to tell you that I will be going to cover the obstetric emergencies, like various parts of obstetric emergencies. I have added trauma and pregnancy also. What is the consequences of trauma over a pregnant patients, and how you are going to manage those patients. And then after that, few aspects about your hemorrhagic problems in the pregnancy. Especially, I will deal about the postpartum hemorrhage. Few important things related to your physiological changes of pregnancy. One diagram I will discuss, and then after that, I think a few important like amniotic fluid embolism, like your peripartum cardiomyopathy, and then at the and few other like your in which important means I have omitted that infection and pregnancy part, because what I feel that it is of not much of use, but yes, definitely you have to read all those things. Now coming to the first important thing, that why these obstetric emergencies. Now we all know till this point of time that these pregnant and postpartum women, who are those patients who requires these ICU admissions? Basically, if you'll understand or if you'll see that only 1% of the all pregnancies and less than 1% of the all ICU admission, it means only 1% of the all pregnant patients requires the ICU admissions. So you just think of this percentage, that is, it is very low. However, it is very low for as a incidence wise, but for you all guys, the questions are very important. And if you'll ask me that what will the primary cause of these admissions, so the primary cause is obstetric conditions rather than unrelated medical complications. That's why many of these patients or many of these women are having these problems in the postpartum period. But exceptions is trauma and cardiomyopathy, which doesn't happens in the postpartum period. It can happens in the any part of the in the pregnancy interval. Now, coming to the next aspect is that the one studies has been also suggested that these SOFA score is one of the better system for predicting mortality in obstetric patients. So, if you have been asked about that, which is one of the scoring system for assessing the mortality in obstetric patient, so you can mark one of the answer like SOFA. So, SOFA is one of the option for predicting the mortality, especially in obstetric patient. Maybe you'll get an indirect question or of some fact based questions in which it may be written somewhere. Now, the second part is the actual mortality rate is mainly depend on the disorders that has caused that patient for that ICU admission. It is not that the mortality is dependent on directly some other factors. It is basically dependent on the disorders. There are various disorders which we will learn. Now, this is one of the study which has been published in Hong Kong Medicine Journal in 2010. And what they have done, they have basically gathered the information of clinical characteristics and their obstetric patients' outcome. Those patients who have admitted inside the ICU or admission inside the ICU, and they have done a 10 years of retrospective study. So it was a good number of patients were there. So you can see that this is the total deliveries, means 37,500 deliveries, and this is the total ICU admissions out of these 10 years, like from retrospective from 1998 to 2007. And out of these 7692 patients, 50 patients were admitted because of the obstetric conditions, and these 50 patients, obstetric patients, were admitted inside the Pamela Nethersole Eastern Hospital. Okay. Now you see that how these incidents is going to get changed. Now they plotted another findings that out of these 50, 35 where the patient admitted inside the ICU is because of the obstetric causes, and rest 15 patients were having the ICU admissions because of the non-obstetric causes. So out of which now you see this PPH is topping the list. So it means that PPH is one of the most important complications which is associated for the obstetric ICU admissions. If you look for the other causes, PIH is another cause in which around 7% of the patient underwent a PIH in these 50. Means out of these 7605 patients, 50 patients were obstetric, and these 35 patients were having these pregnancy-induced hypertension. And these pregnancy-induced hypertension, three findings were there. Few of the patients admitted because of the HELP, few of them admitted because of severe eclampsia, preeclampsia, and then few of the patients admitted because of the eclampsia. It means we have to know PPH, we have to understand the physiology of PIH like eclampsia, then severe preeclampsia and HELP. So I will discuss this two part. And then third part was 6% patient got admitted because of the amniotic fluid embolism. So I feel that's why I have added AFE also as a part. Ruptured ectopic pregnancy, I have not added, but I have definitely added 2% of the causes like peripartum cardiomyopathy. Few things sepsis related pregnancy that you have to read on your own, because in this duration of time it is difficult, almost impossible to cover the all topics. But yes, a few of the important thing has been added here. Now coming to the next part, that what will be the non-obstetric causes. So sepsis is the non-obstetric causes which is covering around 7% of the patient, which includes the sepsis, may UTI, and then chest infection. Few of the cardiac related problems were also there, and then some CNS related like encephalitis, meningitis. So this is about in nutshell about this retrospective study. Then why the importance of obstetric ICU admissions, and if obstetric ICU admissions is there, what will be the obstetric causes and what will be the non-obstetric causes, that you will keep in your mind. Okay? Now the next point is how will you clinically evaluate? How will you clinically evaluate the Okay, so how will you clinically evaluate the gestational age? So again, this is important question that may be asked as a STEM. If you'll pass EDIC 1, you may get a STEM questions in which they can ask that how will you clinically evaluate the gestational age. Now, for evaluating gestational age, it is always important that you need to remember the three basic methods that has to be used for the measurement of gestational age. What are the three basic methods? That is very simple. You obtain a clinical history or your menstrual history, then you perform a clinical examination, and third, you do ultrasonography. Now, first day of the last menstrual period is required for the calculation of an expected date of delivery according to Nagel's rules. We all know that. So add 9 months plus 7 days of last menstrual period. So by which you can calculate the total number or expected date of delivery of using this Nagel's equation or Nagel's rule. Now coming to the next part, that is your clinical examination. So how can you do that clinical examination? So by knowing the size of the uterus. And how will you assess this size of the uterus? By clinically measuring the length from the symphysis to fundal height, which is the best but a crude methods of estimation of gestational age. So what it means? It means if you're going to see doing the clinical examination at 20 weeks of pregnancy, the fundal height should be how much? It should be 20 plus minus 2 centimeters. So it may be either 18 centimeter or 22 centimeter above the symphysis. So approximately which corresponds at the level of umbilicus. So this is another part that for doing that clinical examination. And first part is for obtaining the menstrual history, for knowing the estimated date of delivery or expected date of delivery. Now third part is the ultrasonography. It is one of the most accurate. That the second one was most crude, but it was most accurate method of estimating gestational age. So what are the factors which is going to make these G assessment or gestational age assessment very, very difficult? So if the patient, if the mother is having a multiple pregnancy, if his baby is very big, like fetal macrosomia is there, or if more amount of amniotic fluid has been collected, like polyhydramnios is there, or if the patient is having a features of uterine fibroids. So these questions may be asked in your examination, that what are the factors which makes the assessment of GA assessment difficult, especially on obtaining ultrasonography. So these are the few findings where you may be having a difficulty. Now coming to the next part. So what are the methods that are available to facilitate the uterine displacement? So again, this question is again, they can ask this question, that what are the methods that is available for facilitating the uterine displacement? Because we know that because of the increasing gravid size of the gravid uterus, it may causes your supine hypotension syndrome, or this because of the large size of gravid uterus, it compresses your IVC, leading to the problem. So that's why what are the various method to facilitate this uterine displacement? So in the operating room, so if you are dealing this patient or pregnant patient inside the operating room, a lateral tilt can be applied on the table, right? So this is one of the point where you can apply lateral tilt to the table. Why? Because you have to aim, you have to keep this degree around 15 to 13 degree tilt to the left side. So when you will tilt to the left, the gravid uterus, because of that gravity, it will not push, or it will not compress the IVC. Second part, you can put a double up pillow, and that can be placed on the patient right hip. You can absolutely keep over the patient right hip to facilitate the inclination to the left. So if you elevate the right hip, the inclination to the left will be automatically there. And third part is your MUD, that is your maternal uterine displacement. So how are you going to do that? How are you going to do maternal uterine so Salal, can you mute your mic, please? Don't try to disturb the class, please. So if you have you can have this manual uterine displacement as well by lifting the uterus. How you lift the uterus? By utilizing your two hands or two hand kephalad, and to the left can be performed. So in this diagram you can see that how these two hands has been used, and this has been this lateral uterine displacement is been applied to this patient only for preventing this supine hypertension syndrome. So these are the methods that can be used or that can be utilized while you are attempting a STEM type questions. Now coming to the next part. So now this is again very important part, that what are the one or two questions will be there from the physiological and physical changes of the pregnancy. I have added few important things, but for your understanding, you go and read definitely. So I have divided into three parts. So what are the parameters that I would look for? What are the anatomical and physiological changes, and how it is going to impact your resuscitation? If you're planning to ongoing resuscitate this patient, so what will be the major problem? So we'll start with upper airway. So upper airway, we all know that these patients have a increased hypervascularity or increased mucosal edema. That's why the difficult airway algorithm has to be in place, and a smaller size of ET tube has to be used. So this is very, very simple. Everyone knows that. Everyone knows that. For diaphragm, this diaphragm is splinted. Basically, the diaphragm is splinting of the diaphragm will be there because of the gravity uterus. And what it will do, again, we all know that because of this splinting, the patient will have a decreased FRC. That's why, because if the FRC is decreased, the patient will have a more prone of hypoxia, or more if you have increased the apneic period, or if your apnea will increase, the patient will have more problem, because already the FRC is compromised. That's why the rapid desaturation happens in these kinds of patient, especially when the splinting will be more because of the more increase in the gravid uterus size. The first point. Second important, that these patients have generally reduced mortality, and they have increased gastric pressure. Intragastric pressure is increased, so they have increased risk of either GERD or aspiration. Now coming to the physiological changes, which they used to ask in the exam, that what will the affect, how much changes in the minute ventilation will be there. So this minute ventilation will increase approximately close to 45 to 50% of the patients. So normally from the baseline, 45% increase in minute ventilation will be there. So if minute ventilation will increase, what will happen? The PaCO2 in the blood will be not retained. The PaCO2 will be slowly going to get decreased, and that's why the patient will have a decreased buffering capacity. And so if these buffering capacity is going to get affected, so what will be happen? The chances for acidosis in these groups of patients will be more, because the buffering ability of the body will be compromised. That's why the acidosis will be more. And the second point, the oxygen consumption of the in these groups of patients is generally increasing by 20%. Okay, so why? That's why the hypoxia is more likely, or the second cause is because of that decreased FRC. So these are the two important cause why the hypoxia will be there. And if you look for these, how much decrease in FRC, so it is around 25% decrease in FRC. That's why these patients develop hypoxia, but earlier hypoxia. And then comes considering to the chest wall compliance, what will happen to the compliance? Decrease secondary to the uterus, and then displacing the diaphragm cephalad, making a diaphragm in a splinting position. So what it will do, it will decrease the transalveolar pressure. So your transalveolar pressure will going to get compromised. Now coming to the next part, that what will be the next important thing, that if you look for this part, so here again the important aspect is on your yeah, on your plasma volume. So what will be effect on plasma volume? Plasma volume will increase by 50%. So what it will do? It will produce a dilutional anemia effect, which we all know. The oxygen carrying capacity of the blood will decrease, which we have discussed. That's why these patients have enhanced physiological reserve against the hemorrhage. So if the hemorrhage will be ongoing, the physiological reserve is more. That's why the God has made the physiology like this, so that if something goes wrong to this patient, the physiology comes into action, and then that's why the plasma volume is increased, only to combat the hemorrhage process that has been started. If it has been started to into a pregnant patient, how these plasma volume is going to play a role. And now the second point is heart rate. This heart rate is going to increase by 15 to 20 beats per minute. Cardiac output is going to increase by 40%. So now the chest compressions during CPR likely to be less effective as demand is higher. That's why the cardiac output is very, very much compromised here, and the cardiac output is going to increase by 40%. That's why chest compressions may be less likely effective if you are doing in CPR. Now come to the arterial blood pressure. Arterial blood pressure is falling by 10 to 15%, and that's why the physiological reserve will decrease here. Now coming to the uterine blood flow, so it accounts for around 10% of the cardiac output at term, and it is potential for your massive blood loss. Coming to the cardiac anatomy, we know that this heart is rotated more cephalad and to the left, and that's why the next part is the chamber size will increase, particularly the left atrium chamber will increase more, and that's why these patients are more prone for dysarrhythmia and SVT. Okay. Now coming to the maternal acid-base physiology during pregnancy, I have just added a table and I have added the values in kilopascal as well as millimeter of mercury. So if you'll see that in non-pregnant, like for us like normal people or normal female patients, the ESU2 value is 40 millimeter of mercury or 5.3 kilopascals. The PO2 is 13.3 or 100 millimeter of mercury. The pH is 7.4 and the bicarbonate is 24. Now you just see how this each semester is affecting the different acid-base physiology. So now if the POCO2, we have already discussed that the increased POCO2, the value of because of the increase in imminent ventilation, the PSCO2 is increased, and every time it is increasing. So almost either increasing, it's not means the minute, because of the increase in the minute ventilation, the PSCO2 is decreasing in the blood, and it is around 30 millimeter of mercury. The PO2 is almost 107, 105, and 103, and the ABG pH, or if you'll talk about the pH is slightly alkalotic. Okay, slightly alkalotic, because the buffering capacity is going to get compromised. That's why the acidic feature is not there. The alkalotic features is there, and bicarbonate almost same, that is 21 to 20 and 20. Now coming to the next point. Now this is again an important question, that what will be the vasopressors of choice in pregnant patients? So there are lots of vasopressors that has been used in the pregnant patient, but I will tell you in a tabular format that why these vasopressors, which vasopressor has to be used, and why these vasopressors which you think has to be used, why it has been not been a choice for many of the pregnant patients. Now till now we must understand this physiology, that many of the patients undergoing either elective cesarean sections or your emergency cesarean sections, or having a normal vaginal delivery. So for elective or emergency cesarean section, you have to give subarachnoid block, okay, or spinal anesthesia in these groups of patients, and because of starting a spinal anesthesia, the maternal hypotension will be there. So what happens mostly what happens, that vasoconstriction mostly occurs in all vessels during the pregnancy. So this is normal physiology, that in normal pregnant patients, all these vessels undergo major vasoconstrictions. So what will happen? It is important to select the agent, because of this vasoconstriction, the uteroplacental circulation or uteroplacental blood flow is going to get compromised. Okay, so you have to opt for a choice of agent which have a property of dilating the blood vessels, not further constricting the blood vessels, because if it is further going to constrict, it is further going to impede the uterine blood flow. That's why we will opt for a drug which has maximal dilatation capability of the uterine vessels. How it will be done? If they have on, because these vessels have only alpha receptors. Okay, so uterine vessels are maximally dilated. Why? Because they contain only alpha receptors. So that's why it has an important role in determining the sensitivity to any of the sympathomimetic agents if you're going to add. So this is normal physiology, and this is what we all want. So that's why the alpha 2 vasoconstrictors is being used. Now there are two drugs that usually comes in our mind, that is your ephedrine and your phenylephrine. Now amongst this, which is better? Don't look for other three or four drugs. First, we'll discuss these two, that amongst ephedrine and phenylephrine, the two important drugs which has been solely used by the many of the anesthesiologists. Now, first, ephedrine, definitely it is a preferred. Okay, it has a good safety record as well. It has a minimal effect on the placenta low doses. So if you are using low dose ephedrine, so it has minimal effect on the placenta. And these phenylephrine, this causes more uteroplacental vasoconstriction. So it is, if it is compromising more uteroplacental vasoconstriction in a already constricted uterine vessels, so it will have a more detrimental effect. But just look for the other options. So here, ephedrine, it crosses the placenta, and it has been reported to cause fetal tachycardia and acidosis, especially in the compromised fetus. Okay, and then best, that's why if you want to use, you can use it as a bolus agent only for if a hypotension is short-lived. So if a short duration of hypotension is there, it is preferred that you can use a bolus agent. And why? Because it can crosses the placenta. It has been reported leading to fetal tachycardia and acidosis, which as a neonatologist they doesn't want, which as a obstetrician they doesn't want, and being an anesthesiologist or intensivist who doesn't want that, because if a fetus is already compromised, it is further compromising the fetus. But for here, there is not more fetal acidosis or any adverse neonatal outcome with ephedrine. Okay, and here that's why phenylephrine should be considered as an infusion agent of choice if you feel that if longer duration of therapy is needed, and if the hypotension is of more longer duration. Ideally, the hypotension should not be aggravated; it should be managed very earlier. So you have two choices. So for bolus, ephedrine, but the preferred choice is always phenylephrine and in infusion doses. Now coming to the dopamine, what they have done, that they have studied in few sepsis patients. Overall effect on the uterine heart blood vessel has been not been found, and these dobutamine is a better choice inotropes, especially we all know if the patient is having some forms of cardiac issues. Okay, it means because it doesn't increases the pulse rate and it doesn't affect your mean arterial pressure. Okay, why? Because they told that over dobutamine, which is better. So dobutamine is a better choice inotropes because it increases the pulse rate, but it doesn't affect the mean arterial pressure. Now coming to the vasopressin, what will be the option answer? The IV and IM doses of administration of vasopressin has caused uterine contractions. And coming to the NORAD and epinephrine for managing that hypotension which has caused due to subarachnoid block. So these are considerable vasoconstriction, and they compromise the placental vasculature as well, especially in hypoxic women. And here the last point is short term you can use epinephrine, especially for anaphylaxis, not for decreasing the fetal blood flow. So this is in nutshell how these drugs are being used and what are the various findings. Now coming to the next part, next important question. So you just all guys just be ready, and anyone you can mark what you feel that which statement is true and which statement is false. You just write the answers in the chat box. So this is a question related to a woman trial, and this is one of the famous trial that has been used for checking the effectivity of antifibrillatory trial or antifibrillatory drug, especially tranexamic acid, has been used for the treatment of which kinds of patient? For the postpartum hemorrhage. So whether this tranexamic acid is useful for the treatment of PPH. So you have to mark the true and false statement. So all of you participants, what you feel that is right, you can mark in your chat box. So first option is woman trial has provided a reliable evidence that tranexamic acid reduces the mortality and hysterectomy in women with clinically diagnosed PPH. So first statement. Second, they targeted a tranexamic acid ranges dose, means loading dose of 2.5 to 100 milligram per kg body weight, and maintenance dose of 0.25 milligram per kg body weight per hour to 4 milligram per kg body weight per hour. That has to be given over a period of 1 to 12 hours. The third option is this tranexamic acid passes into breast milk in a very low concentration and approximately 100 of the concentration of the maternal blood. The fourth statement is this tranexamic acid will be compared with matching placebo in this study, and in matching placebo they have used DNS 0.9 sodium chloride and dextrose 5%. The women trial is a randomized, double-blind, placebo-controlled trial, which has been done in 13,000 of women with a clinical diagnosis uh, of your postpartum hemorrhage. I think answer was already there, but any of you who want to attempt this question? What do you feel that which statement is absolutely true and which statement is you feel that is false? Anyone who want to answer? Just I will give 4 or 5 seconds. No one is interested in attempting this question. Good. So you feel that almost all options are true. Okay. Anyone? Okay, not an issue. So just you see that why these statements. Now, the first statement is true. This provided a reliable evidence that this tranexamic acid is going to reduce the mortality. And the second part is not true. So this option is not true. And then third option is again true. This tranexamic acid passes into breast milk, but in a very low concentration. And then these both statements are false. Now you see why. Now, this was a study protocol. This was a Shakuri trial, which was an open access trial. You all guys can go and read this woman trial also. And this was a international randomized double-blind placebo-controlled trial. The link has been provided here, but you can when you will type the woman trial, you will get this. Entire literature. So here what they found, they basically aim to determine the effect of early administration of tranexamic acid on mortality, and then hysterectomy and other morbidities, and with a clinically diagnosed postpartum patients. So what they have done, they have done this trial on a large pragmatic randomized double blind placebo controlled trial among 15,000 women, not 13,000 women, with a clinically diagnosis of postpartum hemorrhage. Okay. And the fundamental ability was that they must be having used this antifibrillary agent, particularly in pregnant women with postpartum hemorrhage. And this treatment entails a dose of tranexamic acid in a tune of 1 gram IV injection. And in the placebo, sodium chloride was used only, and it has been given as soon as possible after the randomization. The second dose may be given tranexamic acid if 30 minutes bleeding continues, or if it stops or restarts within 24 hours of the first dose. So I will advise that you can go and read this trial. So these are the various options of this question. So based on that, this is a randomized based on not on 13,000, on 15,000, and here the tranexamic acid has been compared with matching placebo of not DNS, it is only 0.9% sodium chloride. Okay, and then the dose is 1 gram loading dose. Now come to the next part. So now coming to the interesting topic, that is trauma in pregnancy. So why? Because this is the leading cause of death in almost all age groups, including those childbearing age. That's why these maternal trauma can complicate around 7% of the pregnancy. The data is a bit old because it has been taken from the older literature. Maybe it has increased up to a bit, but the 7% of the all pregnancies having a maternal trauma that has been quoted here. And why? Because of these motor vehicle crashes, because of the fall, assaults and burn, and the severity pattern and mechanism of resultant injuries may varies widely from country to country. That's why what they have given a statement that proper seat belt that has to be applied in the pregnancy patient associated with primary prevention of maternal trauma, and it has got a supportive evidence. So there you must advise to apply proper seat belt because it has got a supportive evidence. Now coming to the next part, National Highway Transport Safety Administration USA, they recommended that any pregnant woman wear their seat belts with the shoulder harness portion positioned over the collarbone between the woman's breast and the lap belt portion under the pregnant womb abdomen as low as possible. So these lap belt should be kept as low as possible on the hips across the upper thighs, not above the abdomen. Okay, so this is how this National Highway Transport Safety Administration have advice for applying this seat belts. Now coming to the management. So if these patients underwent a trauma, so what you have to do? So we know that this pregnancy is producing a multi-system anatomical and physiological changes, which we have just read. And that's why the thorough evaluation, the primary survey, the ABCDE approach is very, very important. And these management depends upon the interpretation of the clinical signs that what that injured pregnant patient is having. And that's why the physiological maternal tachycardia can be obscured because the utility of tachycardia in diagnosing occult traumatic hemorrhage is very, very difficult many of the times. And these fetus has always a low or no chance of survival if the mother is not appropriately managed. So you are going to lose the baby for sure if you're not going to do the proper management to this traumatic pregnant mother or trauma with pregnancy. Now coming to these anatomical and physiological changes, how they are going to affect the pregnancy, because they affect the traumatic injuries as well as the approach to the resuscitation. So both will be affected. Why? Because these uterus always remains an intra-pelvic organ in the first trimester of pregnancy. Because I just discussed about the fundal height of this patient, that how at 20 weeks of pregnancy you can have a fundal heights of 20 plus minus 2 centimeter. That's why why? Because these uterus always remain an intrapelvic organ in the first trimester, where it has been protected by the bony pelvis. So till these remains and the patient is getting a blunt abdominal injury or some penetrating abdominal injuries, it may be going to get protected. But what will happen after 13 weeks of gestation? Because it enlarges in the abdominal cavity, it is now not more inside the pelvic cavity, it is now going inside the abdominal cavity. So it is always more vulnerable to the injuries. So that's why the age cutoff is 13 weeks. So again, this is one of the important MCQ that can come in your exam, that what will be the vulnerable cutoff for trauma or for vulnerable period of a pregnant patients for being injured because of this trauma or because of the blunt injury or because of the penetrating injury. So cutoff may be 13 weeks. And what will be the probable reason? Because now the uterus is no more a intrapelvic organ. Now coming to the next aspect, again by 20 weeks, till we understand that by 13 weeks it is enlarging, but by 20 weeks of gestation it has reached to umbilicus. So it can potentially more cause air to caval compression when the patient is supine. Now again the problem will be there when your patient is having a trauma like your vehicle trauma or motor vehicle accident, and along with you too, you can't keep these patients in a supine position. So what will happen? The two challenges you have to face. So here immediately you have to apply a wedge. You immediately have to tilt the by 10 to 13 degree tilting is required, so that your gravid uterus, in spite of your pregnant patients, you because this patient is having a trauma, so it will be a double sword for you. The managing these patients is very, very important. That's why always these pregnant trauma patients should be kept left lateral tilt or left lateral uterine displacement if you are getting the trauma after 20 weeks of gestation. So carefully read the options if they have given a 20 weeks or 13 weeks. So in 13 weeks, if they have opted for your left uterine tilt or left uterine displacement, and other part is that whether you can keep this patient supine. Yes, till 13 weeks we can keep this patient supine because the uterus is no much gravid. Might be you will be going to get confused and I will mark this statement ki, no, left lateral tilt can be applied. No, but effective left lateral tilt is only if your 20 weeks of gestation is there. Why? Because the uterus will be no more inside the abdominal cavity now. So how will you apply a lateral left lateral tilt? So it has to be 20 weeks of gestation. And how it will be going to affect? So it will be helpful for your management. Why? Because it will maximize the cardiac output, and if the patient is bleeding profusely, so you can maintain the cardiac output by this is one by doing this once after blood and proper crystalloids and colloids can be pushed in. Now coming to the next part. Now this fetus is usually considered a viable when it is more than 24 weeks of gestation, or if the estimated fetal weight is more than 500 grams. So again, these are two important MCQs that can be asked in your exam. Maybe what will be the considered viable age of gestation for this fetus, and what will be according to the fetal weight, what is the cutoff of the fetal weight. Now the reliable assessment of these gestational age we have already discussed, that how will will you identify the gestational age based on these three methods previously that what I have discussed. And then fetal weight may be difficult, maybe these weight may be difficult in different emergency settings, but always useful if you considered if your uterus is above the umbilicus, the fetus may be viable. Okay. Now coming to the next part, emergency delivery of the fetus in these settings of unsurvivable maternal injury or maternal cardiac arrest is emergent, a very emergency. Why? That's why it is also known as perimortem cesarean sections. Many of the time for maternal cardiac arrest, if your patient is not going to if you're not able to achieve the ROSC, so you may go for a perimortem cesarean section within 4 or 5 minutes after non-achievable of ROSC. Now coming to the, if the patient is having a, if you want to, if the patient is having a hemothorax or pneumothorax, like hemothorax, because traumatic injuries because of road traffic accidents and all. So if you want to place the chest tube, again, it is always indicated that to placing the chest tube in 1 or 2 interspaces, it must be higher, 2 or 1 or 2 interspaces higher than the normal because of the diaphragmatic displacement in the late pregnancy. So always check that which weeks of the pregnancy they have asked, whether they have given the cutoff for 13, whether they have given the cutoff for 20, 18, 22, like that. So based on that, you can have this option. Now coming to the next part, that what is basically what acute maternal conditions relating to the fetus can ultrasound examination diagnose in settings of trauma. So again, these are the question. These are the questions for a stem questions. Like they will give obstetric scenario, and after that they will keep asking these sequence, that what acute maternal condition relating to the fetus can be ultrasound, that need ultrasound examination for diagnosing. So here, what you will do, the ultrasound can rapidly diagnose these fetal demise, fetal heart rate, fetal movement, multiple pregnancy, fetal extrusion into the abdominal cavity, like if any uterine rupture has happened or any direct fetal injuries. So these are the 4 or 5 different things which ultrasound can rapidly diagnose. Okay. Now coming to the, in addition to this ultrasound, what extra that we can use is that we can do a fast examination. Okay. So by doing fast examination, it is to perform or is to detect any intra-abdominal pathology. And apart from that, what you can do, these ultrasound, why it is useful for diagnosing your placental abruption, because only 50% of the time, many of the time when you will doing this fast in your ED setups or in your triage area, 50% of the time, because what happens, fresh retroplacental hemorrhage, the echo of this fresh retroplacental hemorrhage is almost same, because that placental tissue density is same in both the situations, in placental abruptions as well as normal. That's why this is very difficult to, because it is in only 50% of the time, these fresh retroplacental hemorrhage is having the same echo density as placental tissue itself. That's why other modalities may be used, like plain radiograph, like open periumbilical your diagnostic peritoneal lavage, maybe sometimes use CT and MRI based on the timing and based on the situations that what has happened, because definitely these MRI comes under secondary survey, these CT comes under secondary survey. That's why many of these plain X-ray comes under primary service. That's why all these findings are important. Now coming to the again important aspect, that what will be the differential diagnosis of the uterine tenderness if the obstetrical patients come inside the trauma. So the differential diagnosis may be placental abruption or uterine rupture. Okay. So how will you know that the patient has a placental rupture or placental abruption? It is very common, especially in BTA, like blunt trauma abdomen, because of the shearing force at the uteroplacental interface. So what will the patient present? Patient will present with a significant consumption coagulopathy, and for which the patient needs a tranexamic acid, some blood products, and then fibrinogen concentrates as well. Now coming to the next part, why it is difficult to differentiate between placental abruption and uterine rupture. So the problem is, if you'll see major placental abruption, the patient will present with profuse vaginal bleeding. The uterus, when you will feel, when you will touch the uterus, the covularis uterus will be there, because the woody hard uterus will be there, and almost impossible to palpate the fetal part. So impalpable fetal part will be there. And when you will do a cardio tachograph, you'll get a painful tetanic uterine contraction, and these are always non-reassuring. So on doing a CTG, the patient will have a painful tetanic contractions. Now, the second part is for placental abruption, the patient will be having a hemodynamic instability, and along with it, the significant coagulopathy. What it will do, if it will be persisting for a minutes to hours, then the patient will have a profound hypofibrinogenemia, and then this hypofibrinogenemia is having cause for major placental abruption. So what is there in these kinds of patients, these ultrasound is maybe many of the times is notorious and unreliable in identifying the placental abruption. That's why the Kleher-Betke test is used to identify to identify the feto-maternal hemorrhage. So this feto-maternal hemorrhage is one of the this KB test is basically used to identify this FMH if it has happened. Although the sensitivity is not too much, it is around only 70% specific and sensitive in detecting these FMH. Now coming to the second part, second DD is your uterine rupture. How are you going to assess the uterine rupture? There the for placental abruption, the woody hard uterus is there, but for in uterine rupture, what has happened? These obstetric patients, they may have spontaneous, or because these may having a spontaneous rupture because of the external trauma. Here the uterus is a scarred uterus. There the uterus is called covularized uterus. So that has to be understand that how this is common. So this is just look like a previous cesarean section or uterine surgery, more common in a scarred uterus if the patient is having a previous cesarean or some uterine surgery. But if you do a cardiac topographic tracing, it is most common clinical sign. How it is how it will be? It will be non-reassuring CTG trace, just like what we have seen in abruptio placentae. Your placental abruption. The patient will have abdominal pain, and then cessation of uterine contraction occurs less frequently. Here, the patient will present with intraperitoneal bleeding, and it is more common than vaginal bleeding. So now this is important aspect which may be helpful in differentiating the both causes like uterine rupture from your placental abruption. And here in fact the vaginal bleeding is less, and the patient will in fact with a severe hemodynamic compromise and coagulopathy, and that's why as a result of concealed hemorrhage. So it is maybe more difficult to diagnose because of that concealed hemorrhage, and the patient, when the patient will be presenting to you, the patient may underwent already in a state of severe coagulopathy or severe hemodynamic derangements. Okay, now coming to the next part, a few points about the FMH like feto-maternal hemorrhage. So what exactly it does? Basically what happens, it happens because of the transplacental spilling of the fetal blood into some part of the fetal blood is mixing with the maternal circulation and resulting in fetal exsanguation and leading to the fetal demise. So what happened many of the time, because of the maternal trauma, 30% of the maternal trauma they associated with the placental abruption, leading to transplacental spillage of the fetal blood into the maternal circulation. So what happens basically? So initial laboratory testing for maternal trauma patients should always include your RHD status of the mother. And if the mother is RHD negative, so what you will do here, the sensitization is the issue. So sensitization will be there, and sensitization with subsequent anti development of the anti-D antibodies. And because of these sensitization, these feto-maternal hemorrhage, this spilling of this fetal blood into maternal circulation can lead to severe fetal hydrops and the death of the intrauterine death in subsequent pregnancy. That's why these patients, trauma patients, if the patient is having a maternal trauma, pregnant trauma, always it is advised to give anti-D immunoglobulin, and it has to be given especially in all patients who are having a RSD negative women having a childbearing age following abdominal trauma. That's why it has been to prevent the problems of that severe hydrops fetalis or the problems of intrauterine death in subsequent pregnancies. That's why the role for NTD immunoglobulin is there, especially in RSD negative patients. Now, these are two important facts. That's why written in red that these NTD immunoglobulins should be given to all RSD negative women of childbearing age following abdominal trauma. This we have already discussed. Now, the second part is some obstetrical service they may conduct this KB testing to quantify to examine the amount of feto-maternal hemorrhage and then to guide the additional dose of NTD immunoglobulin if needed in cases of large hemorrhage. That's why the role of Kluhar bed kit testing is very, very important, because it's basically helpful in quantifying the amount of fetal maternal hemorrhage that has happened, and then leading to whether the next dose of anti-D immunoglobulin is required or not. So this is again important MCQ that may be asked in your exam, that whether how this Kluhar bed kit test is going to add to your diagnosis. And in the setting of other types of trauma like penetrating trauma, thermal trauma, and blast injuries, appropriate directed management strategies has to be prepared. Now, coming to the another point, appropriate thromboprophylaxis, what the literature says is particularly important if the patient is pregnant, because we know that if the patient is pregnant, they are relatively immobilized. That's why the risk for VTP will be more. So thromboprophylaxis need to be added. Now, again, this is another question which is related to your severe preeclampsia. Now, this time, what I request that you all guys can attempt this question. So let me read this question again. It's of true and false statement. I want to check the knowledge related to severe preeclampsia and suspected HELP syndrome. Okay, so this is mark the true and false statement about the patient with severe preeclampsia and suspected HELP syndrome for receiving parenteral magnesium sulfate therapy as a prophylaxis for convulsion. Okay, so here magnesium sulfate regimen include loading dose of 6 gram IV over 20 minutes. The first option. Second, you can give the magnesium sulfate continuous infusion of 2 gram per hour and starting during the period of observation and continuing till 48 hours. Basically, it is a question related to the for abrupting the convulsions that has happened in a patient with severe preeclampsia, and she is also having suspected HELP. So two situations are there, and you have to give this parenteral magnesium therapy as a prophylaxis for convulsion. Now, the third option, if these patients develop recurrent seizure, you can give additional 2 grams of magnesium sulfate over 3 to 5 minutes. And if the seizure is even not controlled by giving these additional doses, you can give 3 max. So this option says that almost 3 boluses of magnesium sulfate, after which you can opt for some benzodiazepines like diazepam, lorazepam, and midazolam can be tried. And ACOG task force, they recommended that antihypertensive therapy for treating severe preeclampsia and HELP syndrome if only the blood pressure is more than 160 by 110. So how many options that you feel that is true and false? Just mark this, mark your true and false statement, please. First, I think I have kept 7 or 8 questions, so if you'll mark it quickly. Okay, so again, you feel that all those options are true. Good. Anyone more who wants to attempt? At least you mark so that you will. Okay, so I think Janath means okay. So first 3 options are false. Next 2 statements are true. Good. So keep attempting. Okay. Now you see that first option, definitely the first option is definitely a true statement. So the loading dose of 6 gram is to be given over 20 minutes. And then second option, no, there is no requirement of continuous infusion. Definitely the continuous infusion of 2 gram per hour is to be given, but here the 48 hours duration is not there. I think it's 24 hours duration postpartum. You can continue until, so half statement is true, half statement is false. If your patient is having a recurrent seizure, again this statement is true, because if recurrent seizure is there, definitely you can add 2 grams of magnesium sulfate, and it has to be given over a period of 3 to 5 minutes. The fourth option is not true. So if the seizure is not controlled by 3 bolus, here no 3 bolus is there. I think it's a 2 bolus is there. And then ACOG task force recommends antihypertensive therapy with HELP syndrome only if blood pressure is 160. There is no cutoff of 180 by 110 or 140 by 110. Okay, so here 160. So this option is again right. Now you see why. Now, this is a statement that has been taken from the 3 different journals. So, if I'll talk about this situation like severe preeclampsia and suspected HELP, the prophylaxis for convulsion is 6 grams over 20 minutes magnesium sulfate, continuous infusion 2 grams, a starting period of observation continuing up to 24 hours postpartum. If recurrent seizures there, additional bolus 2 gram can be given. And then if the seizures are not controlled after two such boluses, you can definitely offer diazepam, lorazepam, and midazolam. And then ACOG task force recommend the antihypertensive therapy with HELP syndrome if blood pressure is 160 by 110. So these are the 4 different options which which may be helpful for you all guys. So this may be asked one of the question that what how the approach for magnesium sulfate therapy for prophylactic as a prophylactic therapy for halting the convulsions in especially severe preeclampsia states. Now coming to the another question that mark the true and false statement for platelet transfusion. So now I want to check the knowledge regarding platelet transfusion and HELP syndrome. So these platelet transfusion is suggested for the patient with class 1 HELP syndrome. These platelet transfusions suggested for the patient with less than 25,000 platelet count before you want a vaginal delivery. Actively bleeding patient with thrombocytopenia and all those patients with platelet count less than 20 per microliter should receive a platelet transfusion and to prevent the excessive bleeding during the delivery. If you want to add corticosteroid to the platelet transfusion, it increases the platelet count. It increases the platelet count and it improves the maternal outcome in HELP syndrome. And if you want to repeat the platelet transfusion, because the short half life of the platelet is very low, that's why the repeated platelet transfusion is required. So many of the options, what do you feel is true or false? So these are tricky options. Maybe while reading you will feel that these all option statement are true and false. So I think first three statements are false, and then the next two statement are true. Anyone, any other, any of you want to attempt? While reading, if this seems that many of the options, yeah, almost all options are true. If I'll go with a one statement, I think every option is true. Okay. First, false, all options are false. Okay. Anyone more? Okay, no issue. So first option, definitely first option is true. The platelet transfusion for class 1 HELP syndrome is required for transfusion because this class 1 HELP syndrome is your Mississippi classification, and this class 1 HELP suggests the significant drop in platelet count. Okay. And the second option, no, this is not required. The platelet transfusion is suggested for the patient less than 25. No, this is not the correct option. The third option is true if a patient is actively bleeding and thrombocytopenia. So always urgently receive platelet transfusion if you are attempting a vaginal delivery. The last two options are not true. These platelet transfusion, if you want to add corticosteroid, it is not going to increase the platelet count, not going to improve the maternal outcome, and the repeated transfusion is not required at all. Even the short half-life of platelet is okay. So these are the one thing. So class 1 HELP syndrome means severe thrombocytopenia. The platelet count is less than 50,000. So always suggested that platelet transfusion is required before cesarean section or when platelets are less than 25,000 before vaginal delivery. Okay. And then these patients mostly these repeated platelet transfusion are not required due to short half-life of platelets. And then these Vigil de Gracia reports, they suggested that if you want to add platelet transfusion to corticosteroid therapy to increase the platelet count, it does not improve the maternal outcome in HELP syndrome. Okay. So these are all those options. Now coming to the next option, which of the following maternal complications can cause hepatic capsular rupture? So now this is again one-liner question that which can cause hepatic capsular rupture. Okay, good. So many of you are going with D, many of you are going with C. Okay. Okay. So the answer is C. Now coming to the next part, which of the following is are the features of severe preeclampsia except? Now here the SBP 160 millimeter or higher or DBP 110 or higher on at least two occasions, at least 4 hours apart while the patient is on bed rest. First, it can define as severe preeclampsia. So new onset of visual disturbances, pulmonary edema, severe persisting right upper quadrant pain, and progressively renal insufficiency with serum creatinine of more than 1 milligram per DL. Which options you feel that are all of the following statements? Take note. Sorry. All of the following statements are true except. Yeah, all of the following are severe features of preeclampsia except. Good. Chalo, badhiya. So this is the option. Now you see why. So this is the first definition, which is almost correct. The second definition is here if the patient is having a severe persistent right upper quadrant pain or epigastric pain, or if a progressive renal sufficiency, how will you know that? If your serum creatinine is more than equal to 1.1 milligram per dl, new onset of cerebral or visual disturbances, pulmonary edema, and these are the few findings. And then thrombocytopenia less than 1 lakh. Okay. Now coming to the next question, all of the following statement is correct regarding amniotic fluid embolism except hypotension is almost most common presenting signs and symptom in 100% of the patient. Chief radiographic abnormalities in AFE are diffuse, bilateral, heterogeneous and homogeneous areas of increased opacity, increased serum tryptase, decreased urinary histamine concentration and significantly higher C3 and C4 complement concentration, base excess increase on ABG and tonic-clonic seizures seen in 10 to 50% of the AFE patients. Mark it quickly. Okay. Good. Okay, so this answer is C. So rest all statements are correct. Hypotension 100%, chief radiographic just like ARDS, and then base excess increase on ABG, tonic-clonic seizures in 10 to 15% of the patients with AFE. So here you have to remember that in these groups of patients, there is no relation of amniotic fluid embolism with serum tryptase. And here the serum tryptase values doesn't going to get affect. The urinary histamine concentration may be sometimes increased, but no significant higher level of C3 and C4 is there. The C3 and C4 complement levels are always normal, and there is decrease or normal serum tryptase level. Okay. Now coming to the next option, the true and false statement regarding amniotic fluid embolism. There are two types, typical, classic, which is also known as classic. It has three phases, phase 1, 2 and 3. Phase 1, cardio or respiratory disorder. 2 is coagulation disturbances. And 3 is your acute respiratory failure with ARDS and cardiopulmonary collapse. Atypical have cardiopulmonary collapse that does not occur, and but it is the first symptoms of life-threatening hemorrhage. As hypoxia and hypoxemia is progress, you will get a circumoral or peripheral stenosis. AFE may also occur up to 72 hours post-delivery, and AFE may occur in healthy women during labor, during cesarean, and during abortion, during the second trimester of pregnancy. So true and false statement I want. First option, true or false? I think that first option is true. Second option is again true. Anyone? 2 to 3 seconds more. Good. So many of you are attempting. It's good. Okay. I already talked that first statement is true, second statement is true, third statement is true, fourth statement is false, and then fifth statement is all again true. Okay. Very good. Now see why. Now this is a JOCP paper, Journal of Anesthesiology and Clinical Pharmacology. You can go and search this literature where it was published in 2016. So it is basically this has been taken from a journal, and this was published in Journal of Anesthesiology and Clinical Pharmacology, where the type is mentioned, the clinical classic phases, phase 1, 2, and 3. And then atypical is present, and then here the symptoms has been added. Okay, and here the symptoms has been added further. So how it is going to affect? So it's a good article, interesting article. You all guys can go and read this article. I will not go in details. So this is issue is written April 2016 and JOCP, like Journal of Anesthesiology and Clinical Pharmacology. Now the next point is peripartum cardiomyopathy. So now this peripartum cardiomyopathy, again a very important question here. This patient present within the last month of pregnancy and at the end of the 5th month of postpartum. Now for diagnosis, what do you want? For diagnosis, there should be no history of any cardiac dysfunction or any identifiable cause of heart failure. If identifiable cause of heart failure has been there, no chance of thinking about the peripartum cardiomyopathy, and there should be always a new left ventricular systolic dysfunction. So here the systolic dysfunction will be there. Because of that, the EF will decrease, the EF will go below 45%, and even when you do a Doppler or when you look for the echo, the M mode fractional shortening will be present. And how much shortening will be there? It is less than 30%. And then the fiber length will be more than 2.7 centimeter per meter square, your in diastolic dimension. If you look for this in diastolic dimension, it is around 2.7 centimeter square. So your EDD and your fractional shortening will be also there on M mode. And here, this is the same thing that what I have discussed already. Here, this is section fraction 45, fractional shortening in diastolic dimension more than 2.7 centimeter square. And here the no cause, any recognizable cause of heart failure. So you have to, if this meeting the criteria, consult with cardio, obstetrician, perinatologist. So incidence 1 in 3,000 to 4,000 live birth, women who receive beta agonist tocolytic therapies. Risk factors are advanced maternal age, multiparity, multiple gestation, obesity, and gestational or chronic hypertension. And the second part is these PPCM is almost similar to IDCM, that is your idiopathic dilated cardiomyopathy, and the etiology is viral myocarditis, autoimmune maladaptation due to hemodynamic stress. Many of the time, what happens that because of the increased hemodynamic stress, is there is a maladaptation in this heart system, and then the patient will have a idiopathic dilated cardiomyopathy. The symptoms are onset typically later than 32 weeks of pregnancy, and when blood volume approaches the maximum amount during this, because this is the time when the blood volume approaches the maximum amount, that's why it happens. And now initial symptoms in the last month of pregnancy, what happens? And in the last month of pregnancy and early postpartum, these may be confused with normal complaints, like the maybe the patient is pregnant, the patient is will present with fatigueness, dyspnea, and edema, but you can't know that the hidden problem is that the patient is developing peripartum cardiomyopathy. And both these symptoms, all these three symptoms, happen in exactly the same period. Like these are normal also, and these are helpful for diagnosing your PPCM. But if it happens in the last month of pregnancy or early postpartum, you can think of PPCM more if you do these echo findings and all. And these most PND, most women present with significant heart failure in the forms of paroxysmal nocturnal dyspnea, some new onset of heart murmurs, then JVP distension, and then pulmonary crackles. More, these patients are much higher rate of thromboembolism overall. That's why these patients may have a coronary emboli and thrombotic cerebral infarctions. So these are again important extra thromboembolic features where the patient will present with coronary emboli symptoms or thrombotic cerebral infarctions. Here, the maternal morbidity and mortality approaches to almost 20%. And these requires cardiac transplantation. Many of the patient requires cardiac transplantation, but these normalization, if your ventricle, if your left ventricular functions going to get normalized in these groups of patient, so the prognosis will be good. So always normalization of the left ventricular functions is to be taken care of. But what there are various factors which predict the poor prognosis of this PPCM. I will just let you know after this slide. So many of these patients, 50% of women with PPCM will recover. Okay, only around these 20% of the patient approaches to significant morbidity, but amongst 80%, 50% will recover automatically, and their baseline cardiac functions will or have more than 50% improvement within the 6 months after the presentation. So this is one of the important positive aspects. Second, these carry good prognosis, high mortality rate. Women do not recover within this time, and women who have low ejection fraction less than 25%, they are less likely to have a good outcome. So many of the time, if your EF cutoff is around 40%, or if you're as based on your this guidelines, like if your EF is around 40%, if your EF is around 35%, and if your EF is around 30%, so more decrease in EF, the poor is the prognosis. Okay, and now this is the another important findings that how these patients will have poor predictors of PPCM. So these are the four important predictors. Like first is your hypotension. So first is your ejection fraction. If it is less than 25%, it has carry a poor prognosis. If the patient have in systolic dimension, if it increases to 5.5 centimeter, and it's poor prognosis. On doing ECG, if the QRS time is less than 120 milliseconds, and if in subsequent pregnancy, if this is happening, then it carries a poor prognosis. Okay, now how are you going to treat this patient? Always treat according to your CHF. It is parallel to CHF. We know that these ACE inhibitors are contraindicated in pregnancy, and hydralazine and nitrate should be used. And dobutamine and nitroglycerin or milrinone may be required for the acute management of the patients. Second point. Third, if the pregnancy is in last month, the fetus should not experience the teratogenic effect of NTGs, so it has to be used very, very cautiously. And you know that blood flow to the uterus and the fetus will be improved by the use of NTG. But you just take care that and in which weeks of pregnancy you are using this NTG. Just avoid the teratogenic effect. And then oral regimen of hydralazine and isosorbide dinitrate, dinitrate are they are appropriate for the lactating status after even stabilization. IVIG, pentoxifylline, and prolactin inhibitors are successfully tried. So these are one of the other options. And the dose is 1 gram per kg body weight IV for 2 days. Okay. And how will you know the improvement? By checking for the improvement in left ventricular ejection fraction. Now, another option, IVIG should be reserved if the patient will have some infectious etiology. Definitely infectious etiology, PPCM, you can give a trial because many of the patient, what they have found on poor left ventricular dysfunction, or the chances for TNF alpha increase is more. That's why these TNF alpha inhibitors like pentoxifylline can be used for idiopathic dilated cardiomyopathy, because these idiopathic dilated cardiomyopathy have mostly viral origin or some inflammatory origin or some infectious origin. And how much dose you will use? 400 milligram 3 times a day for the 6 months together with your conventional therapy. Here again, if left ventricular diameter is significantly smaller, there is fewer deaths in the pentoxifylline group in the previous studies they have suggested. Now coming to the prolactin concentration. Now again, this is important question that what is the level of prolactin on PPCM patients. So these prolactin concentration are usually elevated after postpartum. That's why oxidative stress increases the production of prolactin derivative. So it is 16 kilodalton derivative, and what it do? It does endothelial cell apoptosis and then disrupt the capillary structure. So this is pathophysiology of this PPCM, how it is going to affect. So this may be associated with one of the question that whether this prolactin concentration, how it is going to affect the pathophysiology of the PPCM. So it is going to do a endothelial cell apoptosis by increasing the oxidative stress. And now why? For that, you can add bromocriptine and cabergoline for the treatment, because these are prolactin inhibitors and they have very good recoveries in suppressing the level of prolactin. And here only the thing is with bromocriptine that the chances for MI or myocardial infarctions and seizures and severe hypertension will be more, because on using bromocriptine the hypertension will be there and the MI or myocardial infarction or insufficiency will be there. Now coming to the board regimen that is been used for management of this PPCM. Now what is this board? Board B stands for bromocriptine 2.5 milligrams daily for 7 days. O stand for oral heart failure drugs like beta blocker, ACE inhibitors after hemodynamic stability. A stands for anticoagulants, early heparin as prophylactic dose, because these patients are increased risk for venous thromboembolism. R stands for relaxant like vasodilators only if your systolic blood pressure is going more than 110 millimeter of mercury. And then D stands for your diuretics, for furosemides can be used. So this is overall treatment. Now coming to the this is a straight line question, because I have just talked about true about PPCM except development of heart failure in the last month of pregnancy or within 5 months postpartum. So I want everyone to attempt this question, and each of the options which you pick need to be true. Second option, prognosis depend on the normalization of the left ventricular functions, and then in diastolic dimension of LB is more than 2.6 centimeters meter square, and then M mod fractional sorting is less than 30, and board regimen is used for acute PPCM. Okay. Good. So I think many of you have marked it right, because almost most of the options are true. Only this option is not true. Here the cutoff is not correct. Rest all options are true. Okay. Now coming to the another important point, if the patient have a cardiac failure in pregnancy, again, an important concept is there. How will you understand that? So if the patient is having some preload problem, preload, because of this preload dependency, the patient is having a cardiac failure. So always the choice is diuretics. If the patient is having a afterload cardiac failure, so vasodilator, you just check whether this patient is in cardiogenic shock or not. If not, you can add vasodilators, and then you can treat with intermittent positive pressure ventilation by applying PEEP. You can give good sedation to this patient. You can prevent the ventilator dyssynchrony. You maintain the ventilator synchrony by effectively sedating the patient. You can decrease both preload and afterload. You can improve the PO2 and SO2 values. Why? Because it transfer blood supply from respiratory muscles to your vital organs. Now, this is again important point, that why this cardiac failure in pregnancy. So what happens basically inside your cardiac inside your pregnant patients, what happens basically, if you'll follow this Starling law. So now here what happens here, the y-axis is stroke volume, the x-axis is your left ventricle in diastolic volume. So your volume versus stroke volume versus in diastolic volume, that is left ventricle. So what happens that because of the increase in intrathoracic pressure, the venous return will be affected, and if the venous return will be affected, it is going to affect your preload. How it is going to affect your preload? By compromising the left ventricular diastolic volume. So if your diastolic volume will be compromised, so here if you look for this diagram very seriously, there is a point which is known as X point. Okay, so what is there? Till your patient is having a filling ventricle, if the filling volume of the ventricle is increased, leading to progressive increase in your stroke volume. So here, if the left ventricle in diastolic volume is increasing, simultaneously the stroke volume is also increasing. But it will reach a point X where after this point there is no overstretching of the muscle will occur, and then after that the stroke volume will started to fall. Here you see that the stroke volume has fallen. Here at this volume, at this diastolic volume, the stroke volume has fallen. So what happens, many of the things, what happens here, this right side showed, if this falling is towards right side, it suggests that it is because of the cardiac failure. Okay, and if left side it is there, if the stroke volume is towards the left side, it is suggesting that your muscle contractility or overstretching of the muscle is not there. The patient is showing improvement in the stroke volume. Okay, so here it's a very basic concept for your understanding, that how you are going to understand this in diastolic volume as well as the stroke volume graph. And now based on that, what happens, that you can plan accordingly. So here at this point of time, definitely the inotropes could be one of the choice. You can add inotropes here, and it will lead to improvement in the cardiac failure. Okay, that's why if because what will happen, your this will move towards the left, and if it is moved towards the left, it means your muscle contractility started to improve. That's why the concept of adding inotropes is very important. How it is going to improve the muscle contractility as per following your Starling law. So this is how this concept is important to understand. Okay, the next thing is your FLP. I will just read few important points. The mortality is almost equal, just like PPCM 20%. Here it is 18%. Here lipid accumulation occur inside the liver, kidney, pancreas, brain, and bone marrow. The ammonia is basically produced by hepatic cells, which causes excessive fat content in the liver, which eventually leading to focal necrosis, coagulopathy as well, and then profound hypoglycemia. So these patients present with profound hypoglycemia many of the times, and always occur late in the pregnancy. Okay, or immediate postpartum. So 23 weeks, immediate postpartum, late pregnancy, malaise, jaundice, diabetes insipidus may occur, calling polydipsia and polyuria, but this is a rare association. Untreated AFLP may have FHF, pulmonary hepatic failure, and they may develop hypertension, preeclampsia, and then fetal acid-base status may be affected because of the maternal acidosis. Now this patient will have this help. hyperbilirubinemia, elevated transaminase, coagulopathy, and hypoglycemia. So, in severe preeclampsia, HELP syndrome, acute viral hepatitis, all can mimic AFLP. So, be careful on diagnosing. But liver enzymes will be typically much higher with inflammatory liver, or if the liver is very very inflamed, like in hepatitis, the SGPT, SGOT level will be very very much highly increased, and renal failure may be common with AFLP. That's why renal dialysis may be required or RRT may be required. These patients may develop pulmonary edema or ARDS. Intubation, antibiotics, and large amount of blood products is needed. Okay, next, how these patients may worsen within 2 to 7 days after delivery, but they may improve if the improvement in hepatic, renal, hematological, and pancreatic function is there. And during the next few weeks, the patient will have a full recovery. Liver transplantation basically is indicated for fulminant hepatic failure if the patient have underwent liver rupture with necrosis or any hepatic encephalopathy or worsening coagulopathy. Proactivated protein C has been used for treat sepsis associated with AFLP. Although acute bleeding is a contraindication, plasma exchange has been tried, and then what they have found that women receiving plasmapheresis in progressive AFLP with deteriorating mental status, persistent coagulopathy, and renal failure, pulmonary compromise, and major fluid issues, all of them after these situations, the situation resolved within 14 days after completing of 3 TP exchange, like 3 cycles of uh, therapeutic plasma exchange, the patient got improved. Now, differential diagnosis and complications of AFLP. So, what it would be? So, it would be fatty liver of pregnancy, severe preeclampsia, HELP syndrome, viral hepatitis, TTP, and antiphospholipid antibody syndrome. So, here I ask one question regarding that hepatic capsular rupture in the earlier MCQ. So, hepatic capsular rupture occurs in severe preeclampsia. Hepatic failure appears in AFLP. Hepatic hemorrhage appears in HELP syndrome. Hepatic coma appears in hepatitis, viral hepatitis, and subcortical or subcortical microvascular disease or subcortical bleeding, if it will be there, it is in TTP. And then here, APLA, we all know that here multi-organ failure develops. So this is related to your hepatic. And then DD of your AFLP. Okay. Now this is again one question of AFLP. Identify true and false statement. So this is long chain 3 hydroxyl acyl CoA dehydrogenase, means LCHAT deficiency is responsible for 20% of the patients. Histological appearance, on doing histology, the liver is consistent with macrovascular and microvascular fatty infiltration of hepatocytes. Pregnant women, acute fatty liver pregnancy present in second trimester, usually between 20 to 24, and AST and ALT are always elevated in patient of AFLP. ACOG clinical guidelines recommend prompt delivery of in AFLP patients. Just quickly mark true and false statement. I think I have already discussed many of the things. First option, true or false? 90% of the patient maybe. Second option. Third option, 20 or 24 weeks. Fourth option, AST and ALTR findings and ACOG. Okay, good. So here, first option is true. Second option is not true because it causes microvascular fatty acid infiltration, not macrovascular. And the third option is again false. Pregnancy with AFLP present in the second trimester, no, not in 20 to 24 weeks. Second, mostly third, then intrapartum, and then postpartum. And then these AST and ALT are elevated. These are elevated, but not much elevated. What is being elevated in viral hepatitis? Last option, ACOG, also uh, defines a clear-cut clinical guidelines that you deliver this patient as soon as possible. Okay, now the next question, Swenson criteria, I think is straight one. Only the except option has to be taken care of. All of the following are true except. Okay, anyone? Swenson criteria for amniotic fluid embolism. Good. I think just you all guys go and read because this is again very important. So these are the features. These are the clinical features, but lab features they used to ask many of the times. So ammonia, urate, your coagulopathy, your ASTLT, WBC count, hypoglycemia, bilirubin, all will be there. And the patient having a microvascular steatosis on liver biopsy because it's related to your Swenson criteria only. So no macro, only microvascular steatosis on liver biopsy. Okay, next question. Tocolytic induced pulmonary edema. So what is type? So I think This is last 1 or 2 slides. So the use of tocolytics varies, and the most commonly used tocolytics agents in UK being beta agonists, lalbutamol, terbutaline, and rutodrin. In USA, magnesium sulfate is predominant, and other tocolytics like NTG, CCB, cyclooxygenase inhibitors, indomethacin, and oxytocin hormone inhibitors, atosiban. So these are the drugs which can cause. They may ask the question: all the following findings can cause, drugs can cause your tocolytics induced pulmonary edema, except they can ask. Okay. So this is all about from my side. Last, here the beta agonist adverse effect, like how these beta agonist side effects will be: hyperglycemia, hypokalemia, and tachyardemia, may causing salt and water retention. NTG can cause headache, which we all know. Magnesium sulfate can cause hypermagnesemia, like reflex, like your knee reflex, like your compromised urine output as well. So like your cardiovascular failure if your magnesium sulfate values here also based on your serum magnesium level. And then COX inhibitors, they can cause premature closure of PDA. Calcium channel blockers can cause flushing and palpitation and hypertension. And these atosiban cause dyspnea or chest pain. Okay. So these are the few important aspects. If you have any questions, you can you can drop an email, or you can ask any question related to today's topic to Forge, or you can X me at drneeraj_nsp. So this is all about from my side. If you have any question right now, you can ask. If you want to give any suggestion regarding today's class, definitely you can give your inputs to our coordinator. And if you want to give any positive comments or any suggestions for the class, that what you all guys want, I think that will be a great help for all of us. And if no further questions is there, so I think we all can leave and go through the study. This is only a sensitization for you all. It's always better that you finish your obstetric part very quickly and just go through these topics, what I have today taught you. And then after that, you can mark many of the questions, because EDIC 1 clearing EDIC 1 is not very tough, but only the thing is that you have to be very precise in opting your options, because every options has its own marks, okay, for attempting type K or type A questions.
So thank you very much, Neeraj sir.
Okay.
Hope you just dismiss the class, and thank you very much for this outstanding session.
Yeah.
Thank you.
Thank you. Thank you so much.